Oh, right.
Good afternoon.
Good afternoon.
Hey, Ayla, did you meet up with Jeff Cole?
He is texting me right now. Oh,
Okay.
wait. I did meet him, but he's texting to ask how many.
Uh,
About 500.
For
The idea on the number.
Greg just texted me.
Yeah.
So right about 500, which
Exactly.
is
Yep.
awesome. Can everybody hear me? If we can get a little thumbs up, a little nodding. Okay, cool. Well, I know Ayla's time is limited as well, so maybe we should just get started.
I look like I've been running. That's hilarious. Look at my collar.
So let us get started. Welcome everyone. Today is the 26th annual Greater Philadelphia King Day of Service. A number of us, including Dr. Stanford, just came from an extraordinary day of COVID testing at Girard College, which was, I think, amazing.
Mm-hmm.
But this is obviously a time like no other in King Day tradition. But at the end of projects, we encourage people to reflect on the day, talk about Dr. King and his legacy, the relationship between citizen action and who Dr. King was, and whether this sort of civic engagement is something that is not only important enough to do on King Day, but to do every day to really solve pressing problems. I've been repeating it now since we sort of started this initiative, but it all makes sense that we are focused on the health crisis because Dr. King said in 1966 that of all the forms of inequality, injustice in health is the most shocking and inhuman. 50 years later, I think we could say the same thing, given not just the pandemic, but what we've learned from it. As you probably know, the coronavirus has taken just about 400,000 lives. Those are Americans, family members, friends, people we love, and those we hear about each night on the news. On MSNBC, I hear about it on one of the shows, but who have suddenly had their lives cut short. And the health crisis has, I think, also awoken us to a number of other issues like health disparities, racial disparities in healthcare, and systemic racism. Some of it subtle, some of it not. So the theme for this day has been justice and the COVID-19 health crisis. You see Dr. Stanford today. We partnered with Dr. Stanford and the Black Doctors COVID-19 Consortium, which Dr. Stanford started back in late winter after she saw a need, because she saw that Black folks were not getting the same kind of access to testing in particular, but also healthcare in general. And I think that that's something that's concerned her for a long time. So today we ended up testing, Ayla, we just heard this from Ayla's operations manager, 487 people, and that was I think extraordinary. Yeah, when we opened the back gates of Girard College and the cars started queuing up, there were 120 cars on campus, and it wrapped around the corner. And then we also had walk-in testing with, when I was there, about 150 people in the queue. We also gave out PPE with things like masks and gloves and thermometers, hand sanitizer, and also important information about health protocols, the vaccine, and from the COVID-19 Black Doctors Consortium, information about mental health care, which is obviously a key issue that has come out of this. As we talk about the virus, there are also sort of offshoots of that. Food insecurity, which is a huge issue, and we had several locations today distributing food throughout the city. Massive unemployment is also a huge issue, and we had a career exploration expo. We're having this discussion on systemic racism in healthcare. And also one of the great projects, I think, was training of volunteers for the City of Philadelphia's Medical Reserve Corps. And they're assisting at testing sites and at vaccines. There were a number of projects, most of them virtual, and but we're thrilled to be able to have this discussion today. And the one thing that I said at our opening ceremony, and then it was echoed by the mayor and the governor, and we also had the third ranking member with us of Congress, the House Majority Whip, Jim Clyburn from South Carolina. And that is that, you know, today we embrace and celebrate the legacy of Dr. King, his commitment to social action, racial justice, economic and social justice. But it's not enough to be engaged just one day of the year. We have to be making a commitment throughout the year. And Dr. Stanford is a living example of that. And I will turn it over to my friend and colleague, David Brown, but I also want to say that Dr. Saeed Ibrahim, who you can see up there, is one disclaimer, a dear friend, but also a physician and research scientist at Cornell Medicine in New York, and has researched and written extensively on racial disparities. So we have, I think, a great couple of presenters, and look forward to a lively conversation. So with that, I'll turn it over to my friend and brother, Reverend David Brown, who is wears many hats, one of which is he's a professor at Temple University. David?
Thank you very much, Scott. Scott.
Yeah, I know. It's been that long.
Todd, and that's right. It's been a long day, and it's only 3 o'clock. So it's but I really appreciate Todd, just all the work that you and your team continue to do. That's always so appreciated, and the creativity of pivoting and adjusting, of keeping the King Day of Service alive, even in a safe and an appropriate manner. I'm very excited about this conversation.
If I could interrupt you, as I want to do, I do want to pay a special tribute to my colleagues on our Global Citizen team who have been working so hard. My colleague Campbell Bird is up there in the form of a splash of our logos, who is leading this Zoom, but Campbell and our other staff members have been working tenaciously, and as they do all year round. So I just want to give a shout out to them. David.
All right. And it's not an interruption, it's just a continuation, so it's all good. I know that this is going to be a robust conversation, and I'm really anxious myself, as both a facilitator as well as one of the participants, to hear from Dr. Ibrahim and Dr. Stanford, who both have incredible information both to share, but also important opinions and perspectives to offer up as well. I will, just as in terms of playing the facilitator role, encourage folks to use the chat feature. I'm going to ask folks to keep their mics on mute, just to enable to facilitate more of the conversation between Dr. Ibrahim and Dr. Stanford. We will start to have conversation, though, with you, because we know that we've got almost 100 people on the Zoom. So we want to be able to take advantage of technology to be able to field questions. You can certainly send them to, if you use the chat feature, the chat is now open to everybody. You can share questions among yourselves. You can send them to me, and I can pose them as we go forward. So let me get out of the way so we can have more of a conversation with our two panelists. I would like to talk about, certainly Dr. Stanford and Dr. Ibrahim, I know you've both done a lot of work in this area. And we were at a different time. As a matter of fact, Dr. Stanford, you and I shared that podium. Man, the day the world got turned upside down, we were doing some really great things. Again, congratulations on receiving the Howard Swafford Citizenship Award. But that morning was right before the attack on the Capitol that afternoon and evening. And I'm really would love to get both of your opinions, and you can decide on who goes first. How do we, because we know that the next phase of this is we're getting into the vaccination. And again, thank you for all the great work the COVID consortium did to get people tested, but getting into the vaccination and trying to get past an incessant news cycle that has disinformation and misinformation to get this going forward. So I would yield to whomever would like to take that question first in terms of how do we find ways to push through in terms of getting our folks in the community vaccinated. Whoever would like to go first.
I'll go So, good afternoon, everybody. It's nice to see you. Initially, I said to Todd, I'm exhausted. I need a break. But as soon as I sat down and I saw everyone's face, I thought this would actually be very cathartic. And I want to sit for an hour. This is like the first time I've stopped moving all day. So it would be great to just listen to where people are. So here we are. So a couple things. So on one hand, we've got to dispel the myths, but we've got to talk to folks who are hesitant about the vaccine. But you have to do that concurrently with getting vaccine, being available to administer it to the people who want it, right? So all these things are happening at once. And there was the narrative that Black and Latinx folks did not want the vaccine. They don't trust the healthcare system, they don't want it. And we've got to put efforts into convincing them to get it. Okay, I see that, but while you're doing that, you're also making sure there's vaccine available. You have a place to get it. You have a way for people to register, and you're getting the communities most impacted. And that's what we've been doing a lot. David, you probably know we vaccinated over 1,000 African-Americans this weekend, primarily African-Americans. We were in North Philly, and I had to fight to get that vaccine. I'm just going to be honest. I had to fight. You know, people reached out and they said, hey, the convention center has got 2,000 people, and when is it going to be our turn? And when Commissioner Farley said we're moving into 1B, which in the city of Philly includes people with chronic health conditions, it includes 75 and up, it includes the SEPTA workers, teachers, people in congregate settings working and or living, and then there's the whole list. I said, that's a lot of Black folks. We put our link out on Monday, and in 24 hours, maybe it was 48 hours, 1,000 people signed up. And today makes 1 week, over 9,000 people have completed contact forms, 60% of which are African-American. And what that says to me, which is interesting, when we first put it out, it was 90% African-American. And then you saw that number shrink and get 80%, 70%, 60%, and more white. And what that lets me know is that the people who had access to a computer and a link, they jumped on it. But you can essentially double that 6,000 number for all the people that need a piece of paper to fill it out and a church to drop it off at, so they can also get the vaccine, who need a ride and need to be able to call on the phone to schedule theirs. So it's a lot of work to do. So on one hand, you got the folks who aren't sure and are like, I'm never taking it, that we have to listen to and educate. And then you got, on the other hand, the people who are like, I want it, I'm signed up, and I got to fight with the city to get the vaccine. And then the people who are like, I want it, but I can't use this technology to get it. Help me, wait for me. Don't give out all the vaccine before I have an opportunity to get it. And all those things have to be happening in concert. So that's where we are. That's how I would answer the question sort of briefly. To say it all has to be happening at the same time. But what I have found over these 10 months is that there were so many people in the beginning that were like, never, 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 you will not be putting a vaccine in me, who were standing outside in the cold, hoping that we had no shows on Saturday and Sunday so they could receive it. So I think we just have to keep working. It's not one singular conversation. It's a continual conversation, because every time someone's like, yeah, all right. And then the next time they see you, they want to talk to you again. So that's what I would say.
Well, thank you very much for that, Dr. Stanford. Dr. Ibrahim, your thoughts on what we have to do. And thank you, Dr. Stanford, kind of putting that logistic together beyond the perception. So yeah, go ahead, Dr.
Absolutely. Thanks, David. I think what Dr. Stanford said is right on the money. But let me actually take a step back and actually put this in a greater context. We have to understand that there is a marked racial disparity in healthcare, and that really sort of impacts all kinds of health services, from vaccine access to even just the access to healthcare in general. Forget about the vaccine. I have been studying health disparities for over 20 years. I've been a primary care doctor, mostly providing care to veterans in inner city Cleveland, and Pittsburgh, and Philadelphia for over 20 years. I have sort of seen the broad spectrum of how communities of color and disenfranchised socioeconomically communities have been affected by the dysfunction of our healthcare system. So was I surprised by the marked disparities in the COVID transmission and deaths that were happening in the United States? I was saddened by it, a little bit outraged, to be honest with you, but not surprised, because this is really sort of true of the healthcare system. And yes, I think there is a hope now, and the hope's called the vaccine. But the questions still remain. Will the vaccine be accessible to those who want it, as Dr. Stanford has said? Because there's a group of people who want the vaccine. Will it be available? Would it be accessible? Would it be convenient? So that's one question. And then the other question is, what about the ones who are on the fence, as Dr. Stanford said, who need to be sort of nudged in the right direction? What sort of things do we need to do? And I actually sort of believe that what's happening today and what Dr. Stanford and her sort of consortium are doing is exactly what needs to be done. People need to hear from voices that they trust. And they need to be sort of reached to and engaged at the community level. That's what King Day sort of does. That's what Dr. Stanford and her group do, and we need to do more and more of that. You know, the other interesting thing, and I'm going to digress a little bit here, is that the other day I was reading about 1947 in New York. Many of you may or may not know that there was a resurgence of smallpox in New York City in 1947, and we had a vaccine. The city of New York vaccinated 5.3 million people within less than 2 weeks. How did they do it? Well, I realized that the vaccines are different. These vaccines are a little bit more complicated. They require refrigeration and all those things. The smallpox vaccine just required somebody to sort of stick you in the arm. So it's a slightly sort of different, but there's another major sort of difference. And the difference is that we didn't use public health. We didn't use community outreach to deliver the vaccine. We decided to send the vaccine to the healthcare system. And Dr. Stanford knows our healthcare system is dysfunctional. Everybody knows this. This is the most dysfunctional healthcare system in the world. Yet that's where we sent the vaccine. Now, there are a lot of sort of factors that sort of shape that. But the reality of the matter is that we dismantled the public health system that would have allowed us to do a community-based vaccination campaign, rather than rely on a system that we know may be prestigious but dysfunctional to do it. And to this day, we are sort of still trying to deal with that. I mean, the other day I was in a conference call at my sort of institution at Weill Cornell Medicine and New York Presbyterian Hospital in the Upper East Side of Manhattan, where we found out that almost 50% of our non-physician, non-nurse staff at the hospital are people of color. Well, guess how many of them got the vaccine, even though they were frontline people? Only 25% of them were getting it. Some people said that they don't want it, but that's not exactly always true. As Dr. Stanford said, that's not necessarily always true.
Yeah.
Part of it is because they need to hear from people they trust.
Mm-hmm.
And as you know, the old sort of saying goes, you know, in order to take a message and accept the message, you have to accept the messenger.
Mm-hmm.
So when Donald Trump is your messenger about the vaccine, it is difficult to accept it for communities of color. So we need a diverse voices. We need the leadership of the African American and other minority community of physicians and others to be the ones who are talking and communicating about the benefits and the risks of the vaccine to the community. And that's really the way we get to the bottom of this. So why don't I stop here?
Yeah, I appreciate, both of you have kind of touched on so many different issues, and I see there's some great dialogue going in the chat. So keep it coming, folks. Folks are sharing even in the chat and sharing questions that folks are answering as we're giving out this information. So let me kind of go back to kind of like what continues to blow my mind away is that, just as you said, Dr. Ibrahim, the healthcare system is already dysfunctional. Layer that with a pandemic that restricts people from moving. Layer that with what Dr. Stanford said before about, the misinformation or mistrust and things of that nature. Layer that on top of how the system does in fact work. I keep thinking about, and I think, Dr. Stanford, I think I heard you say this you said this even on the call, the fact that you had to fight to get the vaccine this time. I mean, I would even go back to when you decided, like we need to get the Black Doctors Consortium going. Somebody had to do it. And it's like, well, if that didn't happen, and I guess if I can, Dr. Ibrahim, what you just mentioned, we learned some things in 1947. Why didn't those things translate into where we are now? So I'd be really curious, and if whoever would like to tackle it first, if we know so much about what we know, disinformation, lack of access, dysfunction of the system, and so why is this so challenging? And it feels like, and I'll just put my own kind of personal thing, and it might be not to talk politics. Why were we so unprepared? Sounds like the narrative that came out of the siege on the Capitol on January 6th. Why were we so unprepared and not take the lessons that we've learned over these years?
Yeah, let me, I think that Dr. Stanford will probably have a better answer than I can offer, but let me sort of say a few things. Well, first of all, I think the tragedy of this pandemic is that we knew a lot of this was coming. I mean, I've been watching what happened in New York. As many of you know, New York was the first epicenter of the pandemic. And I was really, truly sort of surprised by how quickly our healthcare system fell apart. We couldn't get enough masks for people. We couldn't get enough sort of PPE for our staff. We were actually sort of literally calling China for ventilators. In the middle of the pandemic. So I've never seen a more sort of disorganized approach to a pandemic. But the reason is because this really went all the way to the leadership of the nation. That's what was dysfunctional. You can't fight a pandemic when you have a government that doesn't speak to itself. Our governor couldn't even speak to the president about what to do. So a lot of the reasons why all of these things happen is because we live in a very disenfranchised sort of time. A large number of our communities are very suspicious of the healthcare system to begin with, and there are good reasons for why that is. And even when they're not, access to healthcare system is very difficult for them. I'm now studying actually who died and who lived in New York during the epidemic by race and ethnicity and socioeconomic status. And what we're finding is that the minority patients who ended up in a very understaffed hospitals were almost twice as likely to die than those who went to the prestigious hospitals of New York. Why is that? Well, that's just sort of something we know has been the case for healthcare disparities for years. Let me give you another quick example. I work next to two hospitals that are considered some of the best in the country. One of them is called the Sloan Kettering Cancer Center, and the other one is called the Hospital for Special Surgery. It's the #1 hospital in surgery in the world. Neither of those two hospitals, which are, by the way, for-profit institutions, accept Medicaid. Medicaid insures 50% of people who live in New York. So right there, what you see is that there is a sort of a structural racism and sort of a discrimination that's already part of the healthcare system. And I think that's, it's to that system that comes sort of the vaccine. So yes, I can see why sort of some communities are suspicious. A lot of people were suspicious of this vaccine for the political rhetoric that came with it. This is the fastest developed vaccine in the history of vaccines. So that raises questions. There has been a lot of talk about whether this was rushed for political reasons or not. So I'm not surprised by the hesitation, but ultimately we have to have faith, as they say. And as you know, as King, Dr. King said, well, faith is like, taking the first step, even when you can't see the whole staircase. So we have to accept the science and accept sort of something, but I think that's the reason why there is a problem here, David.
Wow, appreciate that, Dr. Stanford. Go ahead, right ahead.
Man, I mean, so why was it so messed up? Why were we so? Because the hospitals, they don't think outside the box. That's it. When you say something, it's because this is the way we've always done it. This is how we do it, And even on the Vaccine Advisory Committee in Philadelphia, I said, we're trying to come up with these prioritization categories of who should get the vaccine first. And I said, well, the city's 44% Black, 52% or 54% of the deaths, and over 50% of the cases. So if we're using the data, as everyone says, we're using the data, then that should be your prioritization, okay? We follow the data for everything else, but somehow when it comes to it's primarily Black people, now we're not following the data. Now we're following occupations and things like that. And we went back and forth and they said, well, African Americans are primarily in these occupations. So if we vaccinate these populations, then we'll get most of the Black people. Maybe if you were talking about April, but you're talking about January, where most of those people have had COVID or died, and now they're long haulers, and they can't even walk a block without getting short of breath, and they've been laid off from work. And so now that was what they were doing, but they're not doing it. So now they don't work. So now what? So we ended up voting and we came up with chronic health conditions and 75 and up. And that sort of satisfied everybody and it became more inclusive. But think about all the cities across the US that their 1B is 75 and up, and first responders, teachers, restaurateurs, and retail folks. I mean, think about that. How many of those 18 to 65-year-olds, African Americans that have already been impacted will be left out? So,
wow.
Yeah. And about the healthcare system, many of you probably saw the article in the Inquirer today that said that now University of Pennsylvania is planning to give their vaccines out to people who are not in direct contact with the public. I saw that at like 6 o'clock this morning. I was emailing, are you blank, blank, blank kidding me? And here's the issue. When I talk to folks around the hospital that work in the hospitals in the city, they tell me, you know what? We couldn't get a mask for weeks. We were trying to get tested at fill in the healthcare system, and we couldn't get a test. Mainly and sometimes it was, it's going to be positive. What you getting tested for? Literally, because they didn't want their workforce to be reduced. So now when you come to them, same institution, and you say, we've got this vaccine, it'll be good for you. They're like, I don't think so at all. And then you use the Black doctors in the hospital as your people to advocate for your Black healthcare workers. So you're already assuming that they have a relationship potentially with security, the person emptying the garbage, the person transporting the patient, which is an assumption. And you're assuming that that Black doctor, for example, wants the vaccine, a whole bunch of assumptions. And then the biggest part is, it's not my responsibility. Because I'm a Black doctor at your hospital does not mean it's my job to educate the Black staff at your institution. And for that matter, for free.
Wow.
Okay? So rather than get some outside consultants, get some, as someone said, the right messenger to talk to your staff at fill in the blank. We got a lot of medical schools here. Also, like Cornell, where only 25, 30% of the healthcare workers are taking the vaccine. So rather than get some outside people to talk to them, you're going to use the people in-house, right? You're not really going to invest in it. You're going to say you did it. And now after you did it, you're like, well, shucks, we got all this Pfizer on the shelf. We might as well vaccinate everybody within the walls of this campus. Well, wait a minute. What about 1B?
Yeah.
You know, what about all those folks that are sicker that could benefit before your people just because they work at your hospital? These are things that just came out today, so I'm working on it, okay? But what I'm saying is that those are the problems that are wrong with our healthcare system. And that's just for the people that work in the hospital. Remember, 63% of the healthcare workers that died were of color, majority of whom were Black. So it's like nobody, and it's a sad choice when you have healthcare workers of color that are saying, you know what, I would rather take my chances and see how I fare with coronavirus than take a vaccine from my own health institution.
Wow.
I mean,
That's amazing.
the CEOs need to look themselves in the mirror and really look at that. And you're so used to fixing it from inside. We can handle this inside. We got this under control. No, you don't. No, you don't. And to hear, and I know most of them haven't gotten it in the hospitals, to hear now we're already like, we're going to give it to everybody else, but you still haven't gotten your people who are in contact of color. That's a shame. That is a shame.
That is amazing. Just to add to that, David, I just wanted to add that last week, we actually had a town hall meeting that I organized in New York to talk about vaccine and communities of color. And we invited members of the National Medical Association, which some of you may know is the oldest and the largest Black physician organization in the country. They're experts on the vaccine and this issue. And one of the stories that was shared with us by a physician in Los Angeles was really quite remarkable. She said, you know, there is a history of major academic institutions not giving privilege to minority physicians.
Right.
So if you are making sort of the argument that the frontline doctors in major hospitals basically have to sort of stand in the first line, you know, to get the vaccine. Well, what about all those physicians in the community who you've denied sort of privilege to be part of your staff to begin with? And so she said that they were trying to find ways to reach to that community and sort of express that frustration. But it tells you the systemic kind of problems that are part of our healthcare system that seem to really sort of show up over and over again as we go from, you know, how do we manage diabetes and heart disease all the way to how do we deliver a vaccine.
And it can be exhausting when you have to do it all. You got to work in the hospitals, you got to work in the community. But I mean, the blessing right now for me, and I think for many Philadelphians, is I'm at the table. So just imagine if I wasn't at the table. I mean, let's just imagine, let's imagine that we formed the Black Doctors COVID-19 Consortium. And I have to, this is to Commissioner Farley's credit, who put me on the Vaccine Advisory Committee. He put me on, he didn't have to do that, okay? But he said, we need your voice. The city of Philadelphia, the perspective you have is not one that I have as the health commissioner. And he put me on that committee. And so I have a vote like everyone else, right? And so that's a step in the right direction, because so often the people in the community are in the community and they're
Right.
hearing all the concerns of the people who are struggling and their challenges, but they're not at the table when the decisions are made. They're not making any policies, right?
Mhm.
The media isn't listening to them. And so I feel very blessed by that. I'm not taking it for granted. Every time I speak, I make sure it's purposeful and for a point. And if I have to if I had to fight a little bit, that it's worth the potentially burning a bridge to get what we need. And I mean, I'm not gonna lie, I had to push for this weekend, but we were ready. We were ready. We had been doing it. We had proven our track record that we could do this, and so there was really. So then Commissioner Farley said, Eli, how can I help you? I said, you could get me some vaccine. You could get me some vaccine when 85% of the vaccine that's been distributed so far in Philly is to non-Black people. That's what you could do, But I could have that conversation, you see, and that's a blessing. That our relationship, which was not, I don't know what the word is, amicable to start. It was a little like, well, who is this person? Who is she? And then you have a mutual respect and realize we need each other. This isn't just white people's problem or Black people's problem. This is all of ours. When we're all healthier, we all benefit from that.
Right.
When we have a mutual understanding, everyone, has a brighter day with that. We all, and I think he and I see eye to eye with that. And it has only benefited the Philadelphia community because of so.
Well, if I may, because I think that kind of puts on a very important point in that, and this, what always has amazed me from the beginning of this pandemic is that we are trying to make structural change while flying a jet, right? Because people are dying every day, right? Forget building a plane, we're building whether Dr. Ibrahim or Dr. Stanford to take this, the structure of, let's say, our health commissioner happens to be white male, but happens to be a white male that's going to have a listening ear to say, I don't have the perspective you have, Dr. Stanford. And Dr. Ibrahim, I know that some of the work that you do, more often than not, one, getting invited into the doggone room to even get to the table, and then once you're at the table, to be heard. I mean, so we look at the structural, who's making the policy decisions. And I would also say that kind of recognizing that a lot of our Black physicians and so forth, they're small businesses, right? They were teetering before the pandemic, and to be able to even have the privilege, if I can use that word, to say, I will go out and vaccinate, or I will go out and educate, while you still got to keep the lights on, bills paid, and everything else. So how I know, and this is a big question, and I'm watching our clock because I think Dr. Stanford has to scoot out.
Oh, I'm good.
You're good? Okay, because I still want to get people to have these conversations. Right, absolutely. So my last question before we open it up to the group is, how do we build this? We got to, I get what you both said, there's long-term things we have to get done. Absolutely, and we got to keep the pressure on. So how do we make sure that this is not just a moment that we tend to forget, and next year when we're all back to whatever normal is for us, that we still miss the opportunity to move forward? So whoever wants to take that first.
Let me just quickly sort of say, that's a beautiful question, David. The same could be really said about where do we go, with civil rights. The day
where do we go from here?
Today, George Floyd was murdered. The nation was asking itself that question: where do we go from here? And I can tell you that in healthcare, this is like a can't breathe moment for healthcare system. That's really what it is. And so, what are the solutions? The solutions are not easy because for every sort of right thing to do, there are those who will oppose. So I think what we need to do is a sort of to first of all realize that this is a long struggle, and we have to stay with it and sort of be prepared for that. Secondly, we have to change Washington. That's not the whole solution, because Washington has been changed so many times before without addressing the problems. but I think we can't underestimate the importance of having the right leaders in place, in order to, but more importantly and lastly, I think it's the work that this organization does. It's the work that Dr. Stanford and her organization does. That we need more of that. One of the last things I was going to say is that I'm sort of now very engaged in trying to diversify medical schools in the United States. I'm trying to increase the number of underrepresented sort of minorities, particularly African American men who should go to medical school. And one of the major business cases that we try to make is that we need leaders in healthcare who look like the communities that want to hear about these issues. And when you don't have those leaders, it's a problem. The message doesn't go through.
Mm-hmm.
So I think it's just to sort of make a long story short, I think this is a really long struggle, and it takes every energy and every one of us to do it. I'm always reminded. Somebody recently asked me and said, "Well, but I'm a small person. Why does my voice matter?" Well, I'm actually often reminded by John F. Kennedy when he was touring NASA in the early '60s, and he ran into one of the janitors who was walking in the premises, and he said, "Well, what are you doing?" And he said, "Well, Mr. President, I'm trying to help put a man on the moon." Well, he's working on the facility.
Yeah.
So that's the mentality we really sort of need to think about. We are in it, no matter who you are and how small your role is. Mm-hmm. It takes every person and every effort to sort of win this struggle.
Thank you, Dr. Ibrahim. Go ahead, Dr. Stanford. Yeah.
Whew, there was so much packed in there, Dr. Ibrahim. So for those of you who don't know, Black people represent 4.8% of doctors in the United States, 4.8. So if we're 13 or 14% of the population, I hate to say it, but it might be 12% or 10 or 11% after the pandemic. That's how much we represent. So the idea would be great, and we got to get those doctors in the system. But I can tell you, after high school, it was 18 years till I was done school and all my training. So it takes a while. So in the meantime, for the 50% of physicians who are white and the almost 20% that are Latinx and other ethnicities, we have to acknowledge our own implicit bias. We have to realize that some of the how we were raised, our cultural norms, and our experiences impact how we treat patients when they come in the door. And I believe that more hospitals and their administrations need to point that out. And that needs to be a continuing medical education credit, just like we have to learn about, hand hygiene and, sterile technique. That should be part of it. And because it's great, yes, we need more doctors, but to get from 5% to 15% takes a really, really long time. So we got to work with what we have. Okay. So that's one. So how is it not just a moment? I'm hoping, and I've, talked and hinted and whichever with the Biden-Harris administration, that as they talked about 100 million doses in 100 days, and that we need to have reserves on the ground, and we need these big clinics, that rather than overturn everything, that they see the things that are working. Like this in Philadelphia is working. We could be so much more impactful if I had some more nurses, or I had some medical reserve people, that instead of using surgeons to give a shot, which is what I'm doing because that's my group, but they could be explaining, and the 20 of us could be talking about, do you give consent? Do you have any contraindications? And having that conversation, and the medical reserve people could be doing the shot off. But right now I've got transplant surgeons doing shots, but that's because that's my circle. And that's when I called, said, I'll be there. Right. And so just being able to double my workforce or triple would allow us to be more impactful. And that has to come from the Biden-Harris administration. And they need to know what's happening in the communities that's working. And honestly, what we're doing needs to be duplicated across the United States. That's what I think. How it's sustainable and not a moment. I'm already looking at real estate in the city, because it needs to be, this is not just a movement for me. It's next is a health advocacy center and a health equity center that are in the communities, North Philadelphia being the first, and then I would West and then Central, that our focus is when people have Medicaid and they can't get that $1 million, visit with the doctor, that you can come and get the same care at our advocacy center. And have it near a school and have it near the churches. So we're in the community. So I'm concurrently doing that while we're working on this acute problem, because now, and at least in Philly, people know the Black Doctors Consortium. And all I'm going to do is take that COVID-19 out of the title, which was always part of the plan. And it's Black Doctors Consortium, right? And our Health Equity, Health Advocacy Center. So that's so we can work on these health disparities. I mean, because even when COVID is over, we still have cancer and diabetes and hypertension and prostate cancer and on and on and on. And so that needs to be addressed. And I'm committed to doing it, because the health disparities existed 23 years ago when I became a doctor. And it's just that at this point, when I heard it, it was almost like a flashback, like, damn, but I'm 20 years older. This is the same conversation. This time, I'm going to do something different about it. And now I'm committed. So.
Wow. Thank you for that. I see, let me just ask one of the questions in the chat, which I think is a very good one, and keep them coming, folks. I know some of the chat are being answered directly by the panelists, and that's great. But one of the questions was talks about, the fact that, we may be able to get the vaccination, but we won't be inoculated from racism. We won't be inoculated from some of the other issues that continue to almost, and what you both shared, it just kind of, again, blows my mind. Like, yeah, I never thought of it. Wow, that, in terms of looking at the pipeline, or Dr. Stanford, as you mentioned, 18 years, and the other question, here it comes, is that, what we're doing in Philadelphia works, but is not unique. How then do we, and maybe this is a question I'd love to get both of your perspectives, if we can solve some things, can we replicate some things? Can we learn from other places, not just in the States, but around the world, that can help Black and Brown communities, be able to navigate? Because this is going to be it's until the next thing happens, right? As you said,
right.
Dr. Stanford, we're still represented in other health conditions. So the question is, can we replicate? Can we get lessons learned from other places? And at the same time, try to get this systemic racism, which seems to be persistent and intractable, to be able to navigate to get to a better place over time?
Listen, with education, remember Geoffrey Canada and the educational system?
Absolutely.
And the administration decided this is important, right? And what did they do? They supported it financially. And he went all over the United States teaching people how to duplicate what he had done in New York. What's the difference? Why can't Health and Human Services do what we've done? Why? Right? So I'll just leave it at that. And honestly, I'm not the NMA. I'm not Penn. I'm not Jeff. I'm not Temple. I'm one person that decided I'm going to be committed. And I'm going to put my surgical practice aside, and this is going to be my focus. That's what it takes. If you have a big organization, great. But honestly, it takes one person to be a leader, to galvanize others and get it done, who are like-minded. And, I think a lot of my colleagues at institutions, if they weren't worried about their tenure or advancement or the confines of the wall of their institution, they may have stepped out, but I didn't have that as a private practice doc. So I say that to say, you give people the support they needed financially, which for me was my bank account in the beginning, it can happen, right? But everyone's not going to take of their savings and do that, right? And so that's where the government, back to leadership, decides it's worth the investment. We already have a model. You did it for education. Why not? Can't HHS do it right now and start to really change and make it so it's not a line item. It's not a program. It's a line item that year after year after year, it will always be present. That's how you change it.
Can I add one more thing? I mean, that was beautifully articulated, Dr. Stanford. So I believe that it's true that individuals have to take responsibility and really sort of act locally, even though this is a national, if not a global problem. But the solution is sometimes have to be local. And yes, it's true that, you know, what's happening in Philadelphia may be also happening in New York or in Los Angeles, but that's all good. I am personally sort of right now invested in making sure that the health system, I mean, the medical schools produce the future Dr. Stanfords. That's because that's, if we want to sort of, we can't clone her, but we can create, we can sort of find a way to train the future Dr. Stanfords who will be sort of, who are passionate and willing to act locally. But
I'm born in North Philly. That's the other thing.
Yes.
I'm born in North Philly to young parents on public assistance, educated by the public school system. I wasn't at Penn Charter, nothing wrong with Penn Charter. You know, I wasn't at Germantown Academy. I was in the Philadelphia public school system. So this isn't even, I mean, obviously it helps, but it's just being driven and parents telling you you can do anything you want to do.
Absolutely.
And that don't have parents, it's the church leaders, it's the community, it's, you know, it's volunteers just believing in a child. You only need one person to push you.
But let me add one more thing. So to address the issues, how do we also empower people, particularly people of color, to really sort of advocate for themselves and to be sort of more forceful in this search for the right care? Let me draw from my own research. One of the subjects that I study is the use of knee and hip replacement. I have told this story many times to Todd. He knows this by heart now. So minority patients who need knee replacement are about 50% less likely to get it. Wow. 50%. Wow. Now, yet knee replacement is the fastest growing elective joint replacement in the country, and almost 60% of it is paid for by Medicaid and Medicare. So it's not about access. It's about, sometimes it's about not really knowing enough and not trusting the system. 96% of the orthopedic surgeons in the United States are white men. 96%. So you put those two things together and you realize that there's a problem. So one of the studies we did at Penn, by the way, is that we actually used an educational tool that was culturally competent to a bunch of African American and other, Hispanic patients who were referred to orthopedics at Penn, and we educated them about the risks and the benefits of surgery before they actually saw the orthopedic surgeon. We helped them form questions for the orthopedic surgeon. A year later, we found that 85% increase in the uptake of the procedure by minority patients.
Wow, 85%.
85%. And what that said to us is that it's not about something unique. It's about trust. So if there's a way you could empower people with the right sort of information, with the evidence-based information, and if you could help them ask the right questions, they may be more likely to act on their own behalf. So empowering our community is another strategy. But one of the ways to do it is to educate people about what's needed. Yeah.
Yes.
Man, wow. So we're already past our 4 o'clock, and I want to be mindful of both Dr. Ibrahim and Dr. Stanford's time. And I've seen good chat coming, good questions coming through. So I would encourage to do that. But I want to kind of do a time check with Todd in particular, because I know that there are some closing remarks and things of that nature. And I know everyone's tired. It's okay. And we knew that we would run out of time. We knew that. So I want to make sure that that we stay on time, stay on task. And even though both Dr. Ibrahim and Dr. Stanford had said, hey, we can hang for a little while longer, I don't want to extend that beyond their generosity in terms of the time that they've spent already. Rahiri, I see. Go ahead, Todd.
15 minutes. Ayla, do you have that time?
Yeah, I'm just reading through the chat, looking at questions, but yes, I can.
This is great. Let's do that.
Dr. Ibrahim, does that work for you as well?
Yes.
Okay. I noticed that Todd didn't ask me because I've got to be somewhere at 4:30, but that's all right. This is important. Rahiri, I see you have your hand up. Do you want to go ahead and ask a question? I hope I pronounced your name correctly. You have to unmute yourself. Are you there? Okay, Brian, I see you have your hand up. Can you go ahead and unmute yourself and ask your question?
Yeah, thank you. Can everyone hear me?
Yep.
All right. Hi there. I'm calling from a little bit north of Philadelphia. Actually, I'm in Canada, but it's an area I'm studying. I work, and I do have a lot of connections with the US, and definitely, COVID-19 has taken some of them to a better place due to what we're discussing here now. So I guess the biggest question I have is for Dr. Stanford and Dr. Abraham. What language and communication strategies have you found work as we seek to communicate within our communities to increase awareness of the individual ability to effect change?
Thank you.
Well, I can just reflect on the studies that I have done, and I've been studying these issues in terms of surgical care. Not necessarily COVID, as many of you know, COVID is only a year old, but health disparities are decades, if not centuries old. So we've been studying this issue for a while. I think it depends on where people are, because different people come to the healthcare system at different stages. In terms of their understanding, in terms of their needs, in terms of their sort of preferences for what they feel comfortable doing. So you really have to know where people are so that you could meet them there. The problem is that if you assume that everybody comes to the healthcare system seeking care for diabetes and they know everything about diabetes, that's misleading. So you have to find a way to sort of say, what are you first, so that we could start from there. And the evidence itself is not enough. I mean, you have to realize that, as someone once said, it's not enough to know something. You actually, in order to act, you actually have to be emotionally engaged in it. So, first you have to educate people, but that's not sufficient. That's necessary, but not sufficient. Then you have to find ways to motivate them. And motivations come from, listening to trusted voices, families. One of the things that we've tried to do is engage families. Like, for instance, when I was a primary care doctor and I have a very sort of a touchy subject to discuss with the patient, I often ask them to bring their relatives with them. Because that provides a sort of a safe haven, and it's an amazing when someone comes with you, how different the conversation gets. Physicians even communicate with their patients in a different way when they know someone else is sitting in the room listening to them. So that's one of the strategies that we found to be actually very helpful, is engaging the family to be part of the conversation and the care.
Agreed. So for us, in terms of messaging, I've been on social media a lot, and I found that the videos that I post that seem to resonate, and not that I usually have a script about anything, are the things that are just heartfelt. I want to say the Monday I put out the link and said, I want you to sign up. I know you're not sure, sign up. If you're sure, sign up. And if you're in the middle, sign up. Because when it's gone, it's gone. That seemed to resonate with a lot of people. And I think right now it's hard for people to get excited about something that they don't know is coming. You know what I mean? But once I said it's coming, then people are like, okay, now it's time to pay attention. Now it's really time to get whatever my issues are discussed and handled. So I can't say, because people have asked me about the ad campaign and PSAs and things like that, and I've done them, but it's really not one magic quick fix. It's multiple conversations. You'd be hard pressed. And a reporter asked me that once. So what are you going to do? Have conversations with individual conversations all the time? Yeah, you do. You do. Because many people have lived their whole lives. Like, as a young Black child, you went to the hospital when you were so sick that you were about to die. But anything else, your parents or your grandparents took care of at home. You didn't go to the hospital. You didn't mess around with I'm serious. And so even for me, becoming a physician, like, I had to work that through in my mind, what I was learning in the classroom versus how I was raised. And so even my taking the vaccine, like, I had to separate Black Ayla
Yeah.
from Dr. Ayla to really, work through what I was taught all my life, sort of the cultural experience and understanding that I had to ask myself tough questions. So when I decided to do it, it was not a small decision for me at all. And I had already had COVID, so I had antibodies. So I was on, my doctor and I were going to follow my IgG every 4 weeks. And when I didn't have it anymore, I was going to say, okay, I'm ready for the vaccine. And I was good with that. But when people said, what, she's not taking it? Then they were like, no way. So that is the major reason why I took it. I mean, I'm just being honest, because I realized most people, certainly not most Black people, can get their labs drawn every 4 weeks. When they're ready for the vaccine, can show up and say, okay, I'm ready. I'll take my 1A dose now, 4 months later, and get it, right? And I was coming from a place of access that most people didn't have. So I took it and I was scared about it, but I read the science and I was okay. And I was sick as a dog. And I was honest about that. And I was sick because my body had seen either the virus or a protein portion of that virus 3 times. So my immune system was like, I'm gonna knock you out this time. And I felt it, but it was gone after a day and a half. And that's what I would tell someone. I see Mr. Moody in here, people are scared about the side effects. Look, those side effects will be gone in 2 days, okay? I can't imagine feeling like that for 10 days or 14 days, or some of the long haulers still feel like that every day. So if I had to choose between feeling crappy for 36 hours or 48 hours versus 2 weeks or indefinitely or not living at all, I would take the vaccine all day long.
Yeah.
This vitamin D question, listen,
Yeah.
my vitamin D is low 6 out of 12 months out of the year. It's true. African Americans have low vitamin D. That's right. But increasing it is not going to prevent you from getting coronavirus. So I would say, take your vitamins, take your vitamin D. I support that 100%, but it will not prevent coronavirus disease.
Brian, let me sort of close that beautiful remark by Dr. Stafford with a joke, and this is a true one. So I was talking to a friend of mine who practices in Harlem, and he said one of his patients, an African American man, came to see him, and he looked at him and said, we now have the vaccine, and you are old enough to qualify. Would you like one? And the man said, no, I don't know what's in it. And he said, oh, is that the reason why you don't want it? And he said, yes. And he said, but you've been taking Viagra for the last 10 years, and you never asked me what's in it. and then he said, but do you also know who makes Viagra? Pfizer.
There you go.
So the vaccine, you're telling me you don't know what's in it, it's made by the same company. So that was enough to convince that patient to take the vaccine. So sometimes it takes as simple as messaging as that to really convince someone who's hesitant to sort of go ahead and change their mind.
Thank you for that. Thank you for that. I love the parallel to it because at the end of the day, it's all about taking the lead and standing up onto an acknowledgement to your Viagra. All right. Thank you.
That's a great story, and I'm not sure whether or not that's one we should end with, but I see we're close to our 15-minute grace period. Everyone, all the information that was shared today, we're all going to remember that story. But it's a great illustration. So let me hand the controls back over to Todd and his team. First, I just want to say thank you both for allowing me to be part of this conversation. Really, very much so. And Todd, thank you again for allowing me to kind of help navigate this. I got some great notes and some great information that was shared. So back to you, Todd.
This has been a wonderful discussion and a wonderful way to end a great celebration of Dr. King today. So thank you, Dr. Stanford. Thank you, Ayla. Thank you, Dr. Ibrahim, my dear friend. Saeed, as our physician friends have made clear, these racial disparities in healthcare are not just in delivery, but in the whole educational process. They are ever present, and we've learned more of that since the COVID crisis broke out, but they always have been. And 50 years ago, when Dr. King made those comments about inequities in healthcare, it even rings true today. So I hope that the growing awareness, and we've certainly become more aware in this conversation around the health crisis, it calls for change that is not only undertaken by people like our doctor friends here, but there's a place for all of us. And I think that we all have to be engaged. Please join us at Global Citizen for our ongoing conversation series on race, class, and power. We really benefit by these conversations, and I think they're quite motivating for us to be more engaged. So as we celebrate Dr. King's legacy, I think this is both empowering and in building a level of awareness. I think this can be contagious and inspiring for all of us. So Ayla, thank you for all you do. I'm sure you get so little sleep, but it's been wonderful to get to know you in the last 6 months or so. I hope, we want to be supportive of what the Black Doctors Consortium is doing. And Saeed, your work is incredible, but I will see you at the cafe very soon. Our regular haunt. So everyone, thank you for being a part of this, and have a great night.
Bye, everybody. Thank you. Awesome job, Todd. Great leadership. Awesome.
Stay safe.
Yes.
Surely.
Bye.